surveillance ground.
No, Ippuda.
Are we seeing your slides, Professor Venkat?
Yeah, sir. I could see, sir.
Okay, let me put it in. Okay, 53 students are there. It's 8 o'clock. Can we start?
Yes, sir.
Good evening, everybody. Welcome to the clinics of ISG K PG clinics. As I have told just now, it is the last clinics of the season, and I appreciate the cooperation of all the residents as well as all the faculty members who have contributed immensely for the conduct of these clinics. We thought this would be of benefit to the postgraduate residents, DM as well as DNB, who are appearing for this examination, which is happening in within a couple of weeks. So, as the exam pattern for DNB's OSCE, we have decided to run many OSCE sessions, and today also we'll be having an OSCE on not so common liver diseases. To discuss to present today's cases, we have none other than Professor L. Venkatakrishnan, who is the professor and head of gastroenterology and hepatobiliary sciences, as well as liver transplantation unit of PSG Institute of Medical Sciences and Research, Coimbatore. As you know, Professor Venkatakrishnan has an immense experience in the field of hepatology, especially transplant hepatology, and had his special training from France, and he has a fellowship in transplant hepatology. And all of us have benefited from his knowledge in hepatology in previous clinics. And I also welcome today's discussant, Dr. Jagadish Reddy from KIMS Trivandrum and Dr. Rohan from SIMS Chennai. I also welcome all other faculty members who have joined the session, as well as all other residents who have joined the session. Now over to Professor Venkat to start the session.
Thank you, sir. Can we have the first slide, sir? Somebody can share this. There are three cases which I thought I'll just discuss. Somebody is going to.
Dr. Jagdish?
Yes, yes,
Can
sir.
you take the case and this will just go quickly like an OSCE case, okay?
Okay, sir. 17-year-old female patient studying 12th standard, COVID infection in August 2020, hospitalized for 12 days, treated with steroids and anticoagulants, referred for right upper quadrant abdominal pain, loss of appetite and fatigability. no
Yeah,
fever.
she came to us, she was admitted for 12 days and she came to us exactly 1 month. She came to us in September 2020 with the following symptoms. Go ahead, please.
And loss of appetite and fatigability, no fever, and arthralgia present, sir.
Can we go to the next slide, sir? Can we go to the next slide, sir?
At examination, there is no icterus, mild pedal edema present, hepatomegaly present, no abdominal veins, no spleen, no free fluid in the abdomen, had a healed rash in the neck. Other systems normal.
Yeah.
Young
So she is
female.
a young female, 17 years.
Yes, sir.
She had post-COVID status. She was
Yes, sir.
not, she was treated with steroids and heparin at the anticoagulants. She did not receive any remdesivir. And but she recovered and went back, and she had abdominal pain, fatigability, hepatomegaly.
Yes, sir.
So what do you think she can?
Uh,
So she had a hepatomegaly, no spleen, no ascites. That sort of vague right upper quadrant pain and hepatomegaly.
So with the vague right upper quadrant pain, I want to, in view of already patient is on patient steroids. So first I want to rule out infective causes, sir.
No. So she had hepatomegaly.
Yes, sir.
And she paid pending, and she is post-COVID status.
Yes, sir. Infective cause.
Go ahead. What are the possibilities in a young girl?
Yes, sir. Infective causes, or second one will be the secondary to the infective, like bacterial, viral, and protozoal, sir, and or fungal
She's
also.
got no. She doesn't have any fever. She didn't have any prodrome. She had a vague abdominal pain. She had a firm hepatomegaly. So, what infections you think that could have produced here? Hepatomegaly in this case.
Sir,
She has not reported any jaundice.
usually hepatomegaly, generalized weakness.
Look at the situation. She is post-COVID. She's just recently recovered from COVID.
So probably fungal infection, one possibility, sir, because of she was on steroids and recovered from the COVID. So because of immunocompromised.
First of all, she has been, otherwise generally, there are no other major symptoms. She didn't have fever. How does fungal infection of the liver present to you?
Usually infiltrative.
Have you seen fungal infection in the liver?
No, sir, I didn't see.
So fungal infection in the liver, patients are quite sick.
Yes, sir.
And they are possibly part of a disseminated fungal infections. And most of the time, the bloodstream also will have fungemia. That's how the fungal infection of the liver can come to you. Okay.
Or probably any procoagulant like Budd-Chiari syndrome or portal.
No, one could be post-COVID. Have you gone through what are the manifestations of COVID on the liver?
Liver asymptomatic elevation of AST, ALT, sir. And
there can be asymptomatic elevation of transaminitis. Then,
sir, and some people presented with like hepatitis kind of picture. Like
they can have a hepatitis like picture. Third,
the third will be secondary to the thrombosis, like portal vein.
They can have a correct, very good. They can have a vascular thrombosis. Number 4.
And
so the question here is it related? You should discuss as related to COVID, unrelated to COVID. Okay.
Okay, sir.
So related to COVID can be, as you said, COVID itself can produce transaminitis. It can produce hepatitis like picture. It can produce vascular thrombosis. Then in patient, if you have cirrhosis, they can decompensate. Okay.
Yes, sir.
In patient who already had cirrhosis, COVID has also shown to have decompensate. That is one aspect. So 17-year-old girl, what are the other possibilities of a hepatomegaly apart from COVID? She has not reported jaundice. She has not had it.
Sir, unrelated to COVID, I want to rule out any metabolic diseases like Wilson's disease and Wilson's disease. I want to rule out.
One is Wilson's. Number 2, can it be viral? Chronic Hep B.
Possible, sir. Chronic hepatitis B reactivation possible. Chronic
Correct.
hepatitis.
Chronic Hep B reactivation. Number 3rd,
And drug-induced liver injury also possibility, sir.
good. Drug-induced, but she has not used remdesivir. Okay. She can have steatohepatitis secondary to
Steroids, but very
That's
short.
good. Very good. Yeah, very short duration.
And
We didn't have the history. I don't know. Sometimes they discharge and put the patients on a 3-week therapy of. They put a 3-week therapy of methylprednisolone. No.
so that is one.
That's one possibility with steroid-induced steatohepatitis. Number 4.
And autoimmune hepatitis also.
Excellent. Autoimmune hepatitis is a possibility. I think this is the way you need to think. She's a young female who has come to you with a post-COVID status. And she has had an abdominal pain, fatigability. She has not come with this thing of any jaundice, decompensation, nothing. Okay?
Yes, sir.
So I think I would agree with you that this is how you go about seeking that. It could be part of a COVID sequelae or it could be non-COVID sequelae. You think of Hep B, reactivation of Hep B, or it could be chronic Hep B. You can think of you can think of Wilson's metabolic diseases. You can think of drug-induced steatohepatitis. And number 4, autoimmune hepatitis. Can we have the next slide, sir?
So investigation showed hemoglobin 8.7, total count 5,200, neutrophil 68, platelet count 12,08,000, and LFT shows, sir, that one AST, sir.
Platelets
ALT.
are 1,28,000.
Yes, sir. The AST, ALT, sir, which one, sir? AST?
ALT is 660, AST is 442.
442 and
122 is alkaline phosphatase.
Yes, sir.
And albumin is 3.4, globulin is 4.2, and gamma GT is 622.
Yes,
Bilirubin 1.6, ALT 660, AST 442. 122 is the alkaline phosphatase. 3.4 is the albumin. 622 is this.
That's how I can rule out the.
Now, what does it say? It shows.
It shows mixed patterns, sir. Both cholestatic
Predominantly,
and.
it doesn't show much of cholestasis. Our LFT is 139 is alkaline phosphatase. Up to 139 is our alkaline phosphatase. Okay.
So most likely hepatocellular, sir.
It is hepatocellular. Most likely, it is hepatocellular. Okay. So probably she has got, but she doesn't have any jaundice, but she has transaminitis, which is more than 20 times the norm. Okay.
Yes, sir.
Okay.
There is something interesting in the LFT, Professor.
LFT.
Something more.
What is more than this? What do you see?
Albumin,
Then what happens to globulins?
Sir, 4.2 globulin elevated, sir. 4.
Globulins are elevated.
Yes, sir.
Globulins are
Hyperglobulin.
elevated. Where do you get specific globulins get elevated?
Sir, autoimmune hepatitis globulins will be elevated, sir.
Okay.
Or
Any chronic liver disease cirrhosis can have elevated globulins.
elevated globulins, yes, sir.
Then
Age reversal.
any infiltrative disease, sarcoidosis,
Yes, sir.
tuberculosis, lymphomas, all can have elevated globulins. Okay?
Yes, sir.
Multiple myeloma or light chain disease, all this can have elevated globulins. IgG4 disease, which are all can infiltrate the liver, anything can do it. Okay?
Yes, sir.
So there is an elevated globulins here. Viral serology was completely negative, which included hepatitis A and E.
Yes, sir. And serum LDH 220 international units and RBS 122, renal profile normals.
Okay.
But what is that 622?
GGT, that is GGT, no?
622 is GGT, man. Gamma GT.
That's fine. Okay.
Gamma GT.
That also
So
is
you-
abnormal, no?
Yeah, quite high. Just quite high. Okay. So we went ahead and did the ultrasound abdomen. Ultrasound did not show anything. It showed a slightly, they said hypoechoic liver. Then mildly, portal vein was normal, IVC was normal. Doppler was quite okay. So nothing much in the ultrasound. What else you would like to have, Dr. Jagdishwar?
Sir, I want now by autoimmune workup, sir. ANA.
You want cellular plasma? Yeah, okay, go ahead. Sir, can we have the next slide, sir?
Serum ceruloplasmin is 22, serum IgG 46.2, KF ring negative, ANAIF 3+, ANA profile 3+, LKM 1 negative, SLA
LC1, liver cell,
yes, sir,
LC1.
liver cytosol 3+. So
LKM1 was negative, liver soluble antigen was negative, and AMM2 was negative. So what is significant here?
here both ANAIF 3+ and ANA profile LC1 3+, sir, liver cytosol 1 3+.
And what about IgG?
IgG also elevated, sir.
Grossly elevated.
Yes,
What's
sir.
the normal level? The normal level is up to 16.
Okay, sir.
Why is it I'm so worried about IgG? Now that I'm very, ANAIF is okay, ANA profile is LC1 3+ positive.
To any, like because of secondary infection.
Come on, yeah. Now, when you have a very elevated liver enzymes, there is an elevated globulins. The enzymes are having hepatitis-like picture, and you have ANAIF and LC positive. What do you expect the IgG? Why do we do on IgG levels? IgG levels are grossly elevated in autoimmune liver disease.
Yes, sir.
So, what is the significance of IgG? Why did I do an IgG at all in the first place? Okay, I'll explain to you why. Do you know that? Why do we want to do an IgG on her?
No, sir.
Okay, so now what do you want to do next? So serum ceruloplasmin is normal, all viral serology is negative. Here we have IgG is negative, KF ring was negative, ANAIF was 3+, liver cytosol was 3+, AMA-M2 is also negative. So what does it fit into?
Sir, fit into type 1 autoimmune.
Type 1 autoimmune hepatitis.
Right.
So what do you do next?
Next, I want to see this patient almost it will be score also it will be elevated, sir, because high immunoglobulin.
What is the modified autoimmune score?
Score one will be depends upon ANA more than 1:80 plus 2, sir, and this LC1.
This is 1 in 320.
Okay, sir. So it will come full score, sir. And then immunoglobulin levels more than 1.1. So that also it will come.
No, first is gender.
Yes, sir. Female.
Tell me correctly the modified autoimmune hepatitis score. Gender, IgG levels, ANAIF, then
Presence of liver cytosol 1 or anti-smooth muscle antibody more than 1:40.
Yeah, this is 3+ is almost 1 in 320.
Yes, sir. So that also come plus 2, sir.
Okay.
So if score more than 7 definitive autoimmune hepatitis.
More than 6 is definitely autoimmune thing. Between 4 and 6, probable autoimmune hepatitis. Less than 4, this thing. You need liver histology.
Sir, once it confirmed with the modified, not required, sir. Liver biopsy. If
Okay,
when there is
not,
confusion
when
only,
would you
then
like to, when do you think you want to do a liver biopsy? Not in.
when there is a mixed picture like hepatocellular and overlap syndromes,
Very
or
good.
if there is any associated liver disease uh, like alcohol history or uh, uh, liver causes causing injury, or we are unable to determine causes like
Indeterminate cause, or if there's any overlapping delete.
yes, sir.
So anyway, we went ahead and did a liver biopsy. Can we have the next slide? So can we have the next? Yeah.
So, liver biopsy.
What does it show?
Sir, liver biopsy shows some interface hepatitis. There will be a extension of
No, tell me, show me. Can you? Yeah, tell me
He
what.
won't be, he may not be able to.
Yeah, I won't.
So I will enable annotation for him. Just try.
Try one on the. This one.
Jagadish, just try with your cursor whether you are able to make any movements.
sir, I can.
You cannot.
You can see the portal track.
You can.
You can see the portal track.
This is the
And
portal
then-
track. This will be the interface hepatitis. That is extends portal track.
You see a lot of infiltration of
Lymphoplasmacytic infiltration.
lymphoplasmacytic infiltrate. A lot of plasma cells and infiltrates, and you can see interface hepatitis.
Yes, sir.
And,
There is a acidophils. Acidophils feature of acute hepatitis. Any acute
Yeah.
hepatitis,
you'll have
acidophils.
acidophils, correct. So you have lymphoplasmacytic infiltrate and the portal tract. Most importantly, we need to look at the bile duct also. Is there a bile duct proliferation or is there any bile duct injury? Okay.
Yes, sir.
So this biopsy shows evidence of lymphoplasmacytic infiltrate. We can also show the interface hepatitis, and there's also acidosis, which is showing acute hepatitis, and also the few there's not obvious bile duct proliferation. What we are not able to see on this. So what is? Can we go to the next slide, sir? So you discuss the histology. Histology looks more like an autoimmune hepatitis with lymphoplasmacytic infiltrates, lot of plasma cells, and interface hepatitis. Maybe suggestive of autoimmune thing. So
Yes,
diagnosis is what I'm thinking. So how do you treat this patient?
Sir, this patient I want to start with steroids, sir.
So how do you give me the protocol of treatment of autoimmune hepatitis?
Autoimmune hepatitis combination of steroids, prednisolone 40 mg per day plus azathioprine 50 mg per day, sir.
No. We don't have those. Give me the correct guidelines. High dose steroid or the Sheila-Sherlock's regimen. You cannot just start 40 milligrams. No, there are no guidelines to say you just start 40 milligrams.
Sir, ASLD.
What is Sheila-Sherlock regimen? Do you know Sheila-Sherlock? Know the regimens properly for autoimmune hepatitis. There is one regimen where you start at 60 milligrams per day,
Yes,
come down every week by
4 weeks.
Every week by 10 milligrams. And once you reach 10 milligrams, you start azathioprine. Okay?
Yes, sir.
So, what is Sheila-Sherlock's regimen?
Sir,
30 milligrams. No, they'll ask you, doctor, in the question. Autoimmune hepatitis, they'll definitely ask you what are the. You have a very definite. You just can't give 40, 30, 25 like that. Okay. So you do give 30 milligrams per week. The second week you give 20 milligrams. The third week you give 15 milligrams for 2 weeks. Then you come down to 10 milligrams. When you come to 10 milligrams, you start on
Azathioprine.
how much?
With low dose, sir, 50 mg OD for
50 mg, 50 mg azathioprine. That is the what we use for autoimmune hepatitis. We don't use it like 1.5 milligrams or 2 milligram kg body weight like in. Where do you use 1.5 to 2.5 milligram per kg body weight?
ulcerative colitis, IBD.
In IBD you start. But here the regimen is 10 things. So how many months of steroid you will give?
Sir, total 2 months of steroids, sir. Then once the
18 months of steroids. 18 months of steroids. And how long you'll go on with azathioprine?
total, if there is no remission response to the treatment, total 3 years we need to give, sir.
4 years we give, 4 years. Can you withdraw azathioprine altogether? In how much of percentage of people you will be able to withdraw azathioprine?
So there is a chance of recurrence again.
No,
50%.
my questions are very, very good. See,
Yes, sir.
somebody comes and asks you, okay, somebody going to ask you, how long should I take azathioprine? So if you have 100 people who put on azathioprine 4 weeks, how many you'll be able to withdraw? How many you'll not be able to withdraw? And what will be the advice? This is very, very, very important. Because this is a 17-year-old girl, isn't it? So the family will be looking at her future. What is the relapse rate once you start azathioprine?
Once stop the 50% of chance of relapse, sir.
30% is the relapse. 25 to 30% will relapse. So that means you need to keep them going with a small dose of azathioprine. Now the questions come. Okay, you have started on. So now 4 weeks later, she is on 10 milligrams of steroids and 50 milligrams of azathioprine. How do you monitor the disease?
I will check the AST ALT levels, sir.
Now tell me, what are your goals in the treatment?
Goals need to be normalization of AST ALT. It need to
In
be
how many months? In how many months?
in
What
2
is the
months.
time limit you will give to say that I have reached the remission?
Within 2 months, sir.
6 months is the time you have to achieve the remission. Okay.
Yes, sir.
Now I'll come to you. So what are the factors you look for in the remission? What are the normalization should happen?
AST ALT levels should be normalized, sir.
Up to what level? She's a 17-year-old female. What will be your normal SGOT, SGPT?
As per ASLD for females, less than 25, and for males it will be 35, sir.
SGPT below 20 and SGOT below 23. SGPT of 18 and SGOT of 23 in females. Okay. This is not ASLD. This is a big Korean study which came up, especially when we are looking at hepatitis C. Okay. So one is a thing. And then number 2, if she has had high bilirubin should have normalized.
Yes, sir.
Prothrombin should have normalized. Then, now I'll ask you, why did we look at IgG?
And immunoglobulin levels also need to be normalized.
Need to be normalized means that what is the cutoff level?
16.
12. 16 is a normal IgG level, but you need to have an IgG of 12 at the end of 6 months.
Okay. Sir.
Okay. So this patient was put on, as I put on, I generally go with the Shiloselic regimen. She was put on 30, 20, 15 and 10 in October. Okay.
Okay. Sir.
We kept monitoring her. By March, her SGOT was 232, SGPT was 184, and IgG is 26. Now let me ask you. So this patient obviously has not responded. If you have responded, we know that we'll go for 18 months of small dose of steroids and then 4 years of azathioprine. Okay.
Yes, sir.
So supposing she has responded and she is only on azathioprine and she gets married. So what is the pregnancy counseling you will give?
I'll tell her to continue the azathioprine.
Very good, very good. So you should ask them to continue azathioprine even during
Pregnancy and breastfeeding.
and breastfeeding. Excellent. Now, our patient had 256 of SGOT, 182 of SGPT,
Yes.
with 50 milligrams of azathioprine and 10 milligrams of steroids. And IgG level at the end of 6 months was 26.8.
Yes, sir.
Now, let's go and see what can you do now.
Sir, that means it's a relapse, sir.
It's not relapse, it is not responded. She never had her LFT normalized at all.
Okay, sir.
3 months, 4 months. So she is a non-responder. So in an autoimmune hepatitis, when you have a non-responder, how do you go about?
And I want to give high dose corticosteroids, sir. Just high dose.
No. Jagdish, you should tell me all the correct guidelines. Supposing steroids is not, steroids is the thing we don't. We have given a good steroid therapy. We have given the correct regimen. What do you do now? Steroid is only induction. She has got this thing, but she is not a responder. Her enzymes have come down from 662 to 252, 182 to this thing. But at the end of 6 months, still we have not normalized. We have not reached our goal. Can you stop writing it on the chat box, please? Obviously, the candidate is going for the exam. We need to help him out, please. What can you do?
Sir, then I want to start the secondary drug, sir.
No, you should not the secondary, you should not. So first of all, you should know whether azathioprine is okay or not. Okay, is she taking azathioprine?
Okay.
Is azathioprine thing is there or not? So what do you do?
So I'll check the
TGN levels. You check the
TGN.
TGN levels.
Yes, sir.
Okay. So can we have the next slide, sir?
1 second.
So just look at this. Steroid azathioprine response, it's okay. If you have insufficient response, then you look at the azathioprine metabolite. So you take TGN less than 20, 220, address the compliance or increase the dosage of azathioprine. We don't into the thing. Or use allopurinol plus low dose azathioprine. If it is more than 220, we re-exclude alternative diagnosis. Okay?
Yes, sir.
So we looked at it. So our TGM level was more than 220. She has taken, there was no compliance issues. So if that is the case, what are the other drugs, second line drugs you can use in this patient? Next drug, what will you use?
Methotrexate.
No. The next drug is 6-mercaptopurine or MMF, mycophenolate. Okay.
Yes, sir.
So we started mycophenolate on her, and we get up. We went. What is the dose of mycophenolate? So let's just look up the dose because I need to finish some more cases.
500 milligram.
Yeah, up to 1.5 grams to 2 grams you can go.
Yes,
so we gave her 1 gram of mycophenolate of it. Okay.
Yes, sir.
And we continue on 10 milligrams of steroids. But still, after 2 months or 3 months in June, she still had elevated liver enzymes. And IgG levels have come down to 16, but elevated liver enzymes were there. She had a SGPT of 140. SGOT was elevated to 220. This thing was okay. So then what do you do? What are the options now? Suppose he's not responding. There's obviously the third line of treatment, but before the third line of treatment, what do you want to do?
to rule out other causes for elevated.
Other causes have been excluded. Other causes like hepatitis B, C, A, E, Wilson's, everything has been excluded. No CAM. She was not given remdesivir. She did not show STO2 hepatitis as because of steroids. She only showed classical autoimmune hepatitis. There is third line treatment, but before you go to third line treatment, what would you do? We should always revisit the biopsy.
Okay, sir.
Okay, we revisited the biopsy. So when we revisited the biopsy, okay, we told them to take some more sections. It showed intense bile duct proliferation. Okay,
Yes, sir.
bile duct proliferation, and I was stressing on AMA M2 was negative, but there was some inflammation in the bile ducts and bile duct proliferation. It can happen sometimes even in autoimmune hepatitis. So it could either be an associated autoimmune cholangiopathy or
PBC overlap.
excellent. It was probably a PBC overlap, but AMA M2 was negative. So this is what
Negative,
happened. So you should revisit the biopsy, and when we put this patient on ursodeoxycholic acid along with this, now enzymes, everything is normalized.
Okay.
So probably there was an element of an overlap in this patient, and when we put this UDCIP, so this is what you should do. So intensify therapy with this, or go to the second line. The second line is always 6-mercaptopurine or MMF. But if they're not responding to that, revisit the biopsy to look for any hidden bile duct injury or a bile duct proliferation or biliary cholangitis. Okay. So this could have been an overlap. So UDCA, we put her on 15 milligrams per kg body weight, 13.5 milligram per kg body weight. And we went into, then she has responded very well. Now, you should also know what are the third line of drugs, what are the other drugs available to treat autoimmune hepatitis. Can you tell me, apart from steroids, azathioprine, 6-MP, and mycophenolate?
Methotrexate.
They might ask you what are the side effects of mycophenolate.
Mycophenolate, usually GI side effects are more common, sir.
What are the GI side effects?
Like gastritis, loose stools.
They can have diarrhea.
Diarrhea.
They can have
Abdominal
inflammation. They can have esophagitis.
Yes, sir.
Can you tell me the histology of mycophenolate induced injury? What do you see in that? Very classical.
Sir, Zone 3 necrosis.
No, I'm not talking about this in the GI tract.
The other organ.
Other organ. They come with esophagitis. They come with gastritis also. They have a very peculiar apoptosis seen in the histology.
Okay.
Apoptosis. So this is I was really surprised when one of our transplant patient they said this is mycophenolate induced GI. This thing. They showed us these apoptotic bodies, which are very classical with MMF. Okay, please just go through this. Somebody might ask you this question. So, can you tell me the third line treatment?
Third line treatment, methotrexate.
Methotrexate. Can we have the next slide, sir?
Rituximab.
Yeah, rituximab. Can we have the next slide? Most commonly available is tacrolimus.
Yes, sir. Tacrolimus.
Tacrolimus you can do. Then
Severolimus.
which is that you can use cyclosporin. So you can use calcineurin inhibitors. You can use rituximab. You can use infliximab. All these things are third line management. Can we have the next slides? Not doing.
So
1 minute.
this is the last slide of this case.
No, one more, just one more, sir. One more. One more. So you can have tacrolimus, you can have rituximab, you can have methotrexate, you can have cyclophosphamide, and now Sometimes apart from tacrolimus, you can also use everolimus. We use everolimus sometimes when you have renal injury to these patients. Okay.
Yes, sir. mTOR inhibitor.
So your other third line drugs are tacrolimus, cyclosporin, everolimus, infliximab, rituximab, methotrexate. Metho is used, but the data is very, very scarce in methotrexate. We don't have data in autoimmune methotrexate as we have data in inflammatory bowel disease.
Okay.
In Crohn's disease, you have a definite data, you have definite guidelines to do it, but you don't have much data. So these are third line drugs. So the learning objectives, and the importantly thing is, I want to ask you, what is, she has had a COVID. So the important point is, sometimes in one of the studies which recently had come up, about 540 patients with COVID hepatitis, 70 were autoimmune hepatitis. Out of 70, 40 were diagnosed for the first time after COVID. So probably COVID triggered an autoimmune response and they developed, they had an underlying genetic susceptibility, and COVID triggered a phenotypic response to produce autoimmune hepatitis. The second point is all these patients did not have to have a different regimen, or they also responded to usual things. So this is the impact of COVID. It has come in the recent Journal of Hepatology, where in about 540 patients has come from a group from US. 70 were diagnosed with autoimmune hepatitis, out of which 40 were newly diagnosed. 30 already had autoimmune hepatitis. The patients who had autoimmune hepatitis already did not require any other medications to treat COVID, nor there was any bad outcome due to COVID. But the patients who had diagnosed the first time for COVID was probably genetically susceptible and had a phenotype after COVID. On all these patients responded to first line of drug. If you have time, just go through COVID and autoimmune hepatitis response. So this girl, for the first time we diagnosed, she was absolutely normal till she got COVID. In fact, she came to us 1 month later because somebody thought it was COVID hepatitis, and they kept her Ursocol and watched her for 4 weeks before they sent. So learning points here is, number one, when do you suspect autoimmune hepatitis? How do you diagnose autoimmune hepatitis? What is the histology? Clearly know what are the regimens. Don't tell that I'll give 40 milligrams, this, that. Okay?
Okay, sir.
Clearly know the regimens of autoimmune hepatitis. Then you should know when you have an insufficient response, how do you go about it? What is the next 2 second line drugs and what are the third line drugs?
Third line drug. Yes, sir.
Third line drugs. And you need to go for a thing. This is the line of drugs which we could. So this is the thing, and the response of COVID. Response of COVID. So this is what. These are all the drugs which you can do, but you will see that methotrexate has got a very scarce data. So when you rituximab, if they want to give, what is the precaution you will take?
Hepatitis B.
Sir, this one, rituximab, when we are giving this hepatitis B, like I want to check both total anti-hepatitis B total plus HBV DNA levels.
And you want to vaccinate.
Yeah, vaccinate the pig. Yes, sir.
So you'll wait for 6 months.
No, sir. It's a accelerated vaccination protocol I'll follow. Sir.
Very good. So this is what you should know. Okay.
Yes, sir.
Any other comments, sir? Varghese Thomas, sir, Jayanti madam, or anybody?
Jayanti ma'am, are you there? I think the diagnostic criteria, there should not be any confusion at all. Please brush up the diagnostic criteria, the histological findings, as well as the dosage of steroids, the different regimes, etc. Because autoimmune disease is something which we see not so uncommon at all. Many cases we would have seen and managed. So examiners expect you to be up to date. So it needs a little brushing up. That's all. So just brush up your knowledge, maybe in the background of your brain. Plus, please brush it up. That's what I want to say. Jayanti ma'am, are you there? Ma'am, I think it's not there. Okay, can we move to the next case?
Yes, yes, sir.
I just want to ask one doubt. Very often it's said that even in the biopsy of patient with autoimmune hepatitis, some features of even IgG4 disease also is found.
Many, many, sometimes IgG4 levels can be present in even an autoimmune hepatitis. But it is the intensity of the IgG4 levels and your IgG and IgG4 ratio is what happens. And IgG4, if you look at autoimmune hepatitis or any inflammation, sometimes a sparse amount of IgG4 levels can always be picked up. But in IgG4 depots, the intensity of IgG4 very high, and there will also be associated cholangiopathy, associated features of in the imaging pancreas, and sclerosing like picture in this one will always be there.
Other features of IgG4 disease
Will be there,
elsewhere.
definitely.
Thank you. We'll move
In
to
fact,
the next.
for IgG4 disease, when they have other things, they go by the historic criteria. So, histology, all those immune response to steroids, all
that also, I think people should revise the criteria. That is Mayo criteria, Japanese criteria, international criteria. So many criteria are there. So please brush up those things as well. Okay, and the correct cutoff of IgG4, the number of cells required per hypophil to diagnose an IgG4 disease. These are the standard questions which are asked in the examination. So thank you, Dr. Jagdish Reddy. That was a nice discussion, and wish you all the best for your examination. And if the time permits, we will come back to you with the third case. Now for the next case, I invite Dr. Rohan from SIMS Chennai.
Yes, sir. I'm there.
Can we start?
Yes, sir.
Yes, okay.
Yes. Good evening, sir. This is a 27-year-old female physician with a history of change in bowel pattern for the last 1 year. It is intermittent episodes of blood and mucus diarrhea, frequency 6 times per day, small quantity, semi-solid in consistency, urgency present, nocturnal frequency is present, and there's no history of tenesmus. Easy fatigability for the past 1 month, weight loss around 5 kgs for the last 6 months, and history of abdominal distension for the last 6 months, which is progressive painless, no oliguria or edema of lower extremities, no hematemesis, no melena. No history of cough, fever, periumbilical pain, borborygmy, postprandial hurry, tenesmus, perianal swelling or a discharge, no extraintestinal manifestations in the form of joint pain, skin rashes, pruritus, no history of jaundice in the present, no oral ulcers, and menstrual history is regular. Investigations and treatment history, uninvestigated except for a CT abdomen taken in the month of May and referred for abnormal findings in the same. Intermittent ciprofloxacin and metronidazole during exacerbation of symptoms. Diet history, she has a calorie requirement of 1290 kilocalories with a protein of 86 grams per day, and deficit is 300 kilocalories and 40 grams of proteins per day. Menstrual history is normal.
So she was getting, so basically she has got diarrhea, fatigability, and she has developed abdominal distension. Okay. The abdominal distension is progressive, and she's got a mild periambulia. She's got a large bowel, she's got a chronic diarrhea. You think this it's a large bowel diarrhea? Agree. With blood and mucus.
Yes.
So quickly tell me the differential diagnosis of large bowel diarrhea with blood and mucus.
Yes, sir. So this is a large bowel type of chronic diarrhea, since the duration I presume is 1 year, sir. So my differentials for a large bowel diarrhea would be with blood and mucus. The first differential would be either ulcerative colitis or Crohn's colitis.
Number 1, ulcerative colitis.
Yes, sir.
Crohn's
colitis. Crohn's colitis.
Number 2, colitis. Yeah. Number 3.
with this entamoeba histolytica or amoebic colitis can present with bloody diarrhea, but the duration for 1 year it may be
It's too long,
not
and she has
it is too
intermittently
long.
got treated with ciprofloxacin and metronidazole. Husband was
Yes,
also
sir.
a doctor, so he was treating her with ciprofloxacin and metronidazole.
Yes, sir.
What else
Then
can
the
produce large bowel diarrhea?
ischemic colitis can produce blood and mucus diarrhea.
Too young for ischemic colitis.
Yes, sir. Some sexually transmitted diseases or gonococcal or infections, proctitis can be there. That can be one of the causes.
Don't see much of gonococcal or chlamydial infections these days.
Yes.
No history of radiation proctitis.
Yes, radiation proctitis can be one of the
Campylobacter infections can also produce blood and mucus diarrhea, isn't it?
Yes, sir. Yes, sir.
All these
And
things.
any vasculitis also can be
Yeah.
if young female and
any
connective tissue
ANCA
disorder.
any ANCA positive vasculitis can also produce
Yes, sir. For a female,
blood and mucus diarrhea. Okay.
Yes, sir.
So she has a blood and mucus diarrhea, and now she's also got an abdominal distension, which is very progressive. And the abdominal distension, the symptoms are not pertaining to a subacute obstruction. They are not pertaining, but it's a gradual abdominal distension with filling of flanks. Probably she had ascites.
Okay, sir.
So you have a chronic large bowel diarrhea.
Yes, sir.
For 1 year, and now recently she has developed ascites and she has come with fatigability. This is okay.
Yes,
Both
sir.
husband and wife are doctors. My husband happens to be the alumni of PhD, so they brought her to this.
Yes. So I would, on a background of inflammatory bowel disease, the presence of ascites, I would like to consider a differential of primary sclerosing cholangitis, which is commonly associated.
No. You should say ascites to be related to.
Yes, related
IBD,
or unrelated.
Related to IBD per se.
Yes.
So when can you get ascites in IBD?
One of them is primary sclerosing cholangitis, sir. If that progresses to.
Have you seen severe ulcerative colitis?
Yes, sir. With hypoproteinemia, that itself.
Exactly. That's what I'm asking.
Yes.
If somebody has got that, you see there's a nutritional deficiency is there. So simple protein losing enteropathy can produce
ascites.
Okay, so that's one thing. So you need to think of that there may be this one. Okay.
Protein losing enteropathy. Yes.
Yeah, that is most important. Straight away you go for a PSC. You might say every patient does this thing. Have you seen severe ulcerative colitis patients come in?
Yes, sir. And they do have pedal.
They do ascites. Their album will be 1.2, 1.8, and you'll always have what sort of ascites in that?
It's a low protein, low sag ascites.
It's very difficult to look at the sag because already your
very low
albumin
protein.
is very low. Yeah.
Yes, sir.
So one is it could be related to inflammatory. They can have a ascites. Okay.
Yes, sir.
Then
unrelated, sir. If presuming she's
unrelated could be liver. Unrelated
yes.
could be liver. Unrelated could be kidney.
Kidney. Yes, sir.
Yeah.
Because,
unrelated to liver is what?
Presuming she's had bloody diarrhea. If she
so you need to know whether what are the hepatic manifestations of IBD.
Yes, sir. So one of them would be autoimmune hepatitis can be one of the possibilities.
What are the hepatic manifestations of ulcerative colitis? Number one.
One is primary sclerosing cholangitis, autoimmune hepatitis. Yes, sir. Isolated fatty liver can be there. Steatosis is one of the common.
Steatosis can be there because of malnutrition.
Yes, sir. Malnutrition.
Okay.
Then,
or can they have a portal vein thrombosis?
Yes, sir. Ulcerative colitis typically is a prothrombotic condition. So
you can have hepatic vein thrombosis and portal vein thrombosis.
Yes.
Okay.
Yes.
What is the renal involvement?
Renal involvement can be in terms of glomerulonephritis or.
We don't have much of glomerular disease in IBD. You can have renal vein thrombosis.
Yes, sir.
You can have a renal vein thrombosis. That's also a possibility in
calculate.
Yes.
And you can also have, what calculi do you get in IBD, especially Crohn's?
The hyperoxaluria can be
Yeah, and oxalate calculi. you can have.
oxalate calculi. Yes, sir.
Why does they develop calculi?
Because of the fat malabsorption that can precipitate with the dietary calcium,
So
and then
when
the
you have a
oxalate gets
calculi
absorbed.
due to IBD in Crohn's, which part of small bowels is involved?
The proximal
Small bowel. Distal small bowel is also involved. That means
list.
when you have calculi, that means the small bowel is also involved in the Crohn's. Okay.
Yes.
So you can have calculi in IBD. This is how you think of in this patient. The second thing is she has been having a long-term malnutrition. You should always rule out tuberculous ascites. Isn't it?
Yes, sir.
Isn't it? That's also
Unrelated. Yes. Yes.
tuberculous ascites. Good. This is what we think of in this patient. Can we go to the next slide, sir?
I just want to add that if it is a pediatric patient coming with the blood and mucus and the profound malnutrition, we have to consider bookworm colitis as well, especially
Yeah.
for children coming from less hygienic surroundings. They come with even ascites, edema, and long-standing history of blood and mucus. But this is a very rare thing and confined to pediatrics. Shorter history, perhaps vasculitis producing ulcers I have seen presenting like acute colitis, evolving into severe sort of colitis with a deep puncture out ulcers and producing hyperproteinemia, and patient will have severe hyperproteinemia, extremely high levels of hyperproteinemia, and they succumb unless treated fast. Have you seen such cases, Professor Venkit? I have seen a couple of cases where they present like acute colitis, but with and then it prolongs and looks like ulcerative colitis, but ulcers are very deep and profound.
Bookworm and roundworm both can also produce malabsorption, especially in our this one. I have not seen much, sir, but I've seen one where there's one lady who came with a large, always coming with diarrhea, turned out to have a lot of roundworms, which produced something. She came like a small bowel diarrhea, but a lot of roundworms. And ultimately, what we looked at is she's a soil scientist who was doing her PhD. So we used to work with the soil.
Okay,
and
touching soil often.
She went off, turned to other hospital. Everybody treated her with antibiotics, but everybody missed a 69% eosinophils in her. So when she came to us, I was looking at it. She came in the OPD. I sent all the investigations that dewormed her, and she called me the next day and said she passed some 50 to 60 roundworms. So they can come with just like a diarrhea, like any other thing. As Sir said, roundworms, ascariasis, and hookworms can also produce. Interestingly, Harrison includes ascaris as a cause for malabsorption. If you look at the cause of malabsorption, Harrison's internal medicine, ascariasis.
Okay, and
somebody said CRC, colorectal malignancy. It should be fair enough. Young lady with a colorectal malignancy but she was more of a diarrhea. In colorectal malignancy, they come with a small amount of frequent stool, blood, and mucus. Agreed. Young lady, agreed. If there's a large polyp which has turned malignant, that's also a possibility.
Yes.
So polyp or polyposis can
polyposis turn malignancy.
Blood. Yeah. So that diagnosis should be entertained, I think. No,
yes.
even though
I think it's a fair diagnosis to think of in this such patients. And peritoneal
Yes,
do you know the name of the endoscopic appearance of bookworm colitis? It is called coconut cake appearance. Coconut cake, I am sure nobody would have seen. It is actually the remnant of the coconut after pressing for oil. It is the off-white powdery material. So the colon will be sort of studded with these sort of worms studded. You may look into the Google and find out. It is called coconut cake appearance. Okay. I think this is only for historical interest. Sometimes if you are asked such questions in the Viva to have more marks. Okay. Now, can we move to the next slide?
Yes. Sir.
So
aside this pressure kind of thing, as you said, it could be hyperproteinemia, tuberculosis, liver disease. Always exclude viral hepatitis, Hep B and Hep C. primary sclerosing cholangitis, autoimmune, and bud care. Go ahead. Can we have the next slide, sir?
Yes. On examination, pallor was present, no icterus, lymphadenopathy, pedal edema or clubbing, eyes normal, skin normal, cardiovascular examination normal, respiratory system normal, CNS normal. So what was the hepato?
Next.
Yes.
So can we go to the next slide, sir?
On abdominal examination, abdomen is distended, flanks are full, liver is palpable 8 centimeter below the right costal margin, which is firm. Surface is irregular, rounded edges, non-tender. Spleen 5 centimeter below left costal margin, enlargement directed towards right iliac fossa. No visible veins in anterior abdominal wall, flank or back, and shifting dullness was present. Perianal region normal, rectal examination, no blood or mucus on finger stalk. Mucosa felt normal.
So here she had a flank, she had ascites, she had a fairly large liver, which was quite firm, surface was irregular, rounded edges, non-tender, and she had a spleen.
Yes, sir.
Quite a big spleen on her. This is what we had. And there were no visible veins in the anterior flanks or back. They were shifting dull. So obviously, she had a firm hepatosplenomegaly with ascites. And rectal examination, we did not show evidence of fistulizing or fissuring disease. There were no perianal abscesses. Okay.
Yes, sir.
And this is what. So obviously, there was no fistulizing disease. So here we have a patient who's got a chronic large bowel diarrhea, blood and mucus with a firm hepatomegaly, splenomegaly, and ascites. Okay.
Yes.
So quickly tell what are the possibilities.
Yes, sir. So on again possibilities we can divide into related and unrelated to the large bowel diarrhea. I mean, considering both as a symptom complex, the diarrhea together with the ascites and hepatosplenomegaly, then the differentials, the possibility is autoimmune hepatitis is one of the differentials related to the IBD. Because the liver size is also normal. In fact, liver is enlarged. And,
Liver is quite enlarged. Yeah. It was quite
yes, sir. Yes, sir. One possibility I would also keep in mind is a Budd-Chiari syndrome or a hepatic vein outflow tract obstruction secondary to any venous thrombosis. But there are no flank veins.
That's okay.
Not,
not necessarily always, but you keep vascular thrombosis.
Was there any hepatojugular reflux? Was it present, elevated, or absent?
What is it?
Hepatojugular reflux, sir.
Present.
Present. So maybe then that rules out our Budd-Chiari syndrome, hepatic vein outflow tract obstruction. Then the other differentials could be unrelated, could be a reactivation of chronic hepatitis B, viral hepatitis, and also present with.
They have a chronic viral hepatitis or chronic
viral
liver
hepatitis
disease due to viral hepatitis. Okay.
It's decompensating. There is splenomegaly, there is ascites, but liver is.
You will also consider, because of a large liver, any cholestatic liver disease, even though she was not symptomatic.
Yes.
So a probable PSC is also one possibility which you need to think about it. So I agree with you. I think one large liver, as you said, could be just be steatohepatitis, but spleen doesn't happen so much as steatohepatitis. But this patient also has got a possible IBD. She's got a large liver, a spleen. That means she's got evidence of possibly a portal hypertension. So it could be autoimmune, it could be viral, it could be immune mediated, it could be a cholestatic liver disease, which can happen on these patients. Okay?
Yes.
And she possibly has got a portal hypertension. We'll go to the next slide, sir.
On investigations, the hemoglobin was 12.7, MCV is 82, total WPC count is 18,900, neutrophils of 39%, lymphocyte of 53%, monocyte of 5.6%, eosinophils of 0.9%. Platelet count is 229,000. INR is 1.1. ESR 40, CRP 0.4. Serum ferritin is normal, 12.21. Direct bilirubin is 1.7, indirect 0.6. SGPT is 130, SGOT is 241. Alkaline phosphatase is elevated 331. GGT is also elevated 243. And there is a albumin globulin reversal, albumin 2.5, globulin 6.2. And total protein is 8.7 gram per deciliter.
So what do you think this?
Yes, sir. So the as per this, the liver biochemistry pattern is suggestive of both transaminitis as well as cholestatic.
It's got a
features.
mixed pattern.
Mixed pattern. Yes.
Transaminitis has got a mixed pattern with a very high globulin levels.
Yes, sir. And yes, sir. And albumin globulin reversal. Yes.
What's your comment on hemogram?
Hemogram, the platelet count is normal.
What's your comment?
Despite the presence of a liver disease, so a prothrombotic state cannot be ruled out at present. And the MCV is 82. There could be a dimorphic anemia in that case.
It may be
And
normochromic,
neutrophils.
normocytic picture. She's not very much anemic, but her ferritin was low.
But the neutrophils are also just 39% and lymphocytes.
89%. Yeah. There was no thrombocytosis, but her ferritin was low. Ferritins can be low in IBD. So possibly it is anemia of chronic disease, or it may be normocytic, normochromic picture in this. And ferritin is low.
Yes.
So she's got a mixed pattern. She's got a low ferritin. Total count was elevated, 18,900. Her cultures and procal were negative. Can we go to the next slide of investigation, sir?
The renal function test, creatinine is normal, 0.5, sodium 138, potassium 4.07, chloride 104, bicarbonate 22. Ascitic fluid analysis shows albumin of 1.25, SAG ratio elevated 1.25, ADA is 11.6, LDH is 91, total counts 600 cells, but neutrophils just 2%, lymphocytes 70%, mesothelial cells present. Cytology shows inflammatory cells comprising of predominantly lymphocytes, macrophages, and occasional neutrophils, reactive mesothelial cells present. So it's a low protein, high SAG ascites.
So the low soaping
With a
heparin,
normal
LDH is
cell.
normal. We also looked at the ADA, and even the inflammatory cells are not suggestive of tuberculosis.
Yes.
What rules out tuberculosis by cytology here?
Cytology.
We don't get any reactive mesothelial cells in tuberculosis.
Reactive mesothelial cells.
Not very common to have it in tuberculosis. So it is a low protein, high SAR. That means she has got some portal hypertension here. So we have a chronic large bowel diarrhea. She has got with blood and mucus. She has got a firm hepatosplenomegaly. She's got a mixed pattern of hepatocellular and cholestatic pattern. INR is normal, low ferritin, normal platelets, but she's got a low protein, high SAR ascites. Okay.
Yes, sir. So
Yeah. Next.
yes, sir. Viral markers, HbSAg, HCV, HIV are negative. IgG4 is 1.65.
We looked at IgG4 because IgG4 have an innumerable. They can come with intestinal disease, they can come with retroperitoneal fibrosis, they can come with pancreatitis, they can come with cholangiopathy. Okay, they can infiltrate anywhere.
Yes. On the autoimmune workup, liver cytosol 1 antibody is positive. ANA profile is negative. ANA by immunofluorescence shows a nucleus with a fine speckled pattern. Cytoplasm shows reticular pattern, dilution of 1:100. A is negative. Asthma is also negative. Serum ceruloplasmin is normal, 23.63.
Now what next? What do you want to do next? So she got a blood and mucus diarrhea.
Yes, sir.
She's got
First, I would
a,
sorry, sir.
Okay, colonoscopy. Go ahead.
Yes, sir. To characterize the type of diarrhea, the etiology, I would like to do a colonoscopy and take biopsies. On the colonoscopy, entire mucosa from rectum to cecum showed ulceration, loss of vascularity, granularity, contact bleeding, and attenuation of ostra. The Mayo scoring was endoscopic grade 3. So there is evidence of pancolitis here, which is severe.
And what do you do?
I would take biopsies.
Okay.
To
Can we have the next slides?
Do you find anything peculiar in this colonoscopy picture?
There is
All the films.
there
What is
is
what is this?
the cap is used over the endoscope.
Yeah, cap.
On the colonoscopic biopsy, colonic mucosa showed distorted crypt architecture, irregular crypt elongation, crypt loss and cryptitis, regenerative atypia of the crypt lining. Lamina propria shows dense lymphoplasmacytic infiltrate admixed with many eosinophils, dense lymphoid aggregates presence, and eosinophilic crypt destruction presence. So this shows acute on chronic activity because of the crypt distortion architecture loss. I would say there is chronicity, and because of the eosinophils and neutrophils, I would say that there is activity also, acute activity also.
Acute. So they said it could possibly an acute on chronic ulcerative colitis is going on.
Yes. Yes.
Can we have the next? What do you want to do next? Why did we do a endoscopy?
Just to see for esophageal varices, because
Very good.
we were
Yeah.
suspecting portal hypertension in this case. So there were no varices, erosions and erythema and mosaic pattern seen in body and antrum.
Okay, so we have done with the large intestine, which shows possibly acute on chronic ulcerative colitis. But only thing was there were a lot of eosinophils, which is about 40 to 45. So can you tell me the significance of eosinophils in esophagus, stomach, small bowel, and colon? At what numbers will you say that this is eosinophilic esophagitis, eosinophilic gastritis, eosinophilic enteritis, and eosinophilic colitis?
In the esophagus, eosinophils more than 15 per high power field is suggestive of eosinophilic esophagitis. Initially, it was classified as PPI responsive, non-responsive, but now.
Where do you take biopsies for eosinophilic esophagitis?
From mid-esophagus.
What is that rule called? What is the rule? It is called 4-14-4 rule. What is that 4-14-4 rule?
So 4 quadrant biopsies.
4 quadrant biopsies, 4 centimeters above the Z line and 14 centimeters above the Z line. That is called the 4-14-4 rule for eosinophilic esophagitis.
Yes.
4 quadrant biopsies, 4 centimeters above the Z line. If it is more than 20 to 25, it is eosinophilic gastritis. As it goes more distally, it becomes more.
Increase. Yes, sir.
Yeah, anything above 50 is eosinophilic colitis.
Yes, sir.
And anything above 30 to 35 is eosinophilic enteritis.
Yes.
And what should you see in eosinophilic enteritis or eosinophilic colitis in histologically? You saw only eosinophilus, but if you want to say eosinophilic colitis, can you get cryptitis and crypt?
Yes, sir. We can get eosinophilic cryptitis, eosinophilic abscess is also possible.
Crypt abscess is possibility, but when will you say that this eosinophilic enteritis or colitis?
When it
Here we have seen 40 to 45 eosinophils.
Yes, sir.
But is it eosinophilic colitis or is it a part of UC? No.
Because
when
there is
you say
evidence
this is a eosinophilic colitis
yes,
or something.
When in the absence of crypt architectural distortion or
you will have crypt and cryptitis, crypt abscess in eosinophilic enteritis or eosinophilic colitis. But in which layer of infiltration you will say that this patient has got eosinophilic disease?
It will be predominantly in the mucosa and the muscularis mucosa.
It has to go beyond the muscularis mucosa in eosinophilic enteritis or
enteritis.
Please look up that histology. That is very, very important in this.
Yes.
Okay.
Eosinophilic enteritis can involve all the 3 layers of the
It'll interact, it'll even get into the smooth muscles. So that is
Yes.
the most important thing. So now that we have finished with it, now we need to characterize what's happening to the liver.
Yes.
And there is both hepatocellular and cholestatic pattern.
Yes, sir. So the next investigation of choice would have been an MRI with MRCP.
Or a CT. Or a CT.
Or a CT.
She had an ultrasound earlier. An ultrasound showed coarse liver echo texture with ascites. That's why she came to us. Okay.
Yes. Yes.
So we did MRI abdomen with MRCP. What is the thing?
This is an MRI abdomen with MRCP showing there are multifocal strictures, which intrahepatic strictures, as well as there's a dilated gallbladder.
There's a distended gallbladder.
Distended gallbladder.
You can see multifocal strictures intrahepatic and also narrowing
the distal CBD.
Distal CBD.
Yes.
So what does it do?
So probably this could be a dominant stricture in the distal CBD.
She didn't have jaundice.
Yes. So this pattern is but consistent with the primary sclerosing cholangitis.
Consistent with primary sclerosing. And what do you see in the liver?
In the liver, so can I just see the image?
Can we go back to the next slide?
Yeah, the image, the liver looks nodular.
Surface nodularity is
Surface
there.
nodularity is there. And it is enlarged. Hepatomegaly is there. Caudate lobe appears enlarged.
She's got a fairly big spleen.
Yes, sir. Splenomegaly.
Okay. Can we have the reports?
On MRI, right lobe of liver measures 17 centimeter. Surface irregularity noted. No obvious focal lesions. Main portal vein is 13 millimeters. Spleen is 17.6 centimeter. Moderate free fluid is present. Large bowel loops are featureless with loss of haustra. Mild wall thickening from cecum to sigmoid colon. Few small lymph nodes adjacent to sigmoid colon. On the MRCP, intrahepatic biliary radicals, they are prominent with mild wall thickening. Right hepatic duct and sectoral ducts are prominent. Left hepatic duct and sectoral ducts are prominent with luminal irregularity and narrowing with beaded appearance. Appears narrowed for a short segment at the confluence, and common hepatic duct is mildly dilated. The common bile duct is 5 millimeters normal lumen with smooth tapering distally, and cystic duct is mildly dilated, proximal insertion in posterior medial aspect of common hepatic duct.
So she has got possibly co-sector surface suggesting of cirrhosis. She's got a dilated portal vein. So she's got portal hypertension with PSC. So now that we have an ulcerative colitis, which is biopsy proven, she's got cirrhosis of liver with portal hypertension. She has got an MRCP which shows PSC, but she also has a transaminitis with
Transaminitis with positive autoimmune profile in the
positive autoimmune
LC1 is positive.
So what do you do
DNA by immunofluorescence is positive. Sir, to rule out an overlap syndrome, I would like to do a liver biopsy. In this case, a transjugular because ascites is present.
Now, what we did on this is, we went ahead and did a transjugular. I don't know. What we did is she responded very well to diuretics. And then we did a this thing because her INR was 1.2 and the platelets were 2,29,000. So this is our liver biopsy on her.
Yes, sir. So this shows this is a cut section which is showing lymphocytes and fibroblasts around the in the zone. This appears to be the top left. Yeah, this appears to be the zone 1 or around the portal tract. So because I can see the portal vein over here, and There's lymphocytic and plasma cell
There are a
infiltrate.
lot of lymphosplasmacytic infiltrates.
Yes, sir. And
And you can also look around the portal like the bile ducts are all thickened and
yes. Obliterated.
obliterated. Correct.
Yes.
Can we have the next slide, sir?
So the liver biopsy shows fragments of liver tissue with partially effaced architecture. The hepatic lobules show focal necroinflammatory activity. Portal tracts show chronic inflammation. Lymphocytes, plasma cells, and conspicuous eosinophils. Minimal duct inflammation with ductular proliferation. Occasional portal tract showed a bile duct with mild concentric fibrosis. Interface hepatitis present. Occasional hepatocytes at interface showed emperiopolysis and portal fibrosis with portal to portal bridging, and IgG4 staining is negative.
So basically she has got
So there are mixed features of both sclerosing cholangitis as well as interface hepatitis and lymphoplasma.
concentric fibrosis in the bile ducts.
Yes, sir.
Possibly a cholangitis.
Cholangitis. Yes.
Cholangitis. So this final diagnosis here is
It could be a
could be though. Tell me the final
yes,
diagnosis.
Yes, sir. So the final diagnosis will be an inflammatory bowel disease, ulcerative pancolitis, Mayo 3, with acute and chronic activity at present, with evidence of liver disease in the form of with an extraintestinal manifestation in the form of probably autoimmune and PSC overlap. Because of the antibody profile of autoimmune hepatitis, which is positive.
Antibody and most importantly, in the
Interface
LFT it showed
LFT transamine.
a mixed pattern.
Yes, sir.
LFT showed mixed pattern, hyperglobulinemia, isn't it? She had
Yes, sir.
evidence of portal hypertension. Ascites also showed evidence of portal hypertension.
So decompensated liver
and
disease secondary to the
MRCP showed
with
evidence of PSC.
intra and extra hepatic involvement of the bile ducts.
So she had ulcerative pancolitis. She had autoimmune hepatitis with PSC overlap, portal hypertension. Of course, a low ferritin was there. So she had iron deficiency, anemia, and this. So how do you manage this patient?
Yes, sir. So management has multiple issues over here. One is managing the inflammatory bowel disease as well as managing the liver disease.
First is nutrition.
First is, yes, sir.
So you have to manage the ulcerative colitis plus autoimmune hepatitis and PSC overlap.
Yes, sir. So nutrition, I would like to start her on a high protein and salt restricted diet with around 1.2 to 1.5 gram per kg body weight protein per day and calories of 30 kilocalories, 25 to 30 kilocalories per day per kg per day. And along with that, since she already has cirrhosis, I would give her some more suggestions like avoiding fasting for a prolonged period, taking a nighttime snack.
Yeah, one is nutrition. And how do you treat her UC and autoimmune hepatitis and PSC?
Yes, sir. So the presence of pancolitis and PSC, it has two implications. One is the definitive mode of management for the sclerosing cholangitis would be a liver transplant here because the patient is already decompensated. However, the MELD score is 14. Maybe
MELD is 14. Primary sclerosing cholangitis was this. But yes, the fact is that I think she had more of autoimmune hepatitis causing a problem rather than PSC because her bilirubin was only 1.6. Okay.
Yes.
Bilirubin is only 1.6. And I think the MELD was still lower. And I think what really decompensated her was not PSC, was autoimmune liver disease, what has caused her decompensation.
Yes,
so I think she didn't have any cholestatic symptoms. She didn't have any pruritus. she was not jaundiced. Okay, but she had an elevated alkaline phosphatase. She had elevated liver enzyme. So we felt that because PSC was not the dominant among the
in the overlap.
dominant
So
among
steroids.
the overlap. So anyway, ulcerative pancolitis and autoimmune will require
Steroids. Yes, sir.
So after giving her diuretics and everything, we put her on steroids and we treated her. In this particular case, we gave steroids just like what we give for ulcerative colitis. So we went on for 1 month of steroids and then started tapering after 1 month of 5 milligram per kg and added. What else you can add? What other 2 drugs you will add for her?
So one is
Both for autoimmune
azathioprine.
hepatitis and ulcerative colitis.
Yes, sir. One is azathioprine. The other would be ursodeoxycholic acid.
Very good. So we added azathioprine and we added ursodeoxycholic acid. Very well. Portal hypertension is there because of splenomegaly, but she did not have any varices. So
Yes.
she responded very well now. Okay.
For her low protein ascites, I would also like to give her a prophylaxis for HDP because of the.
She was never she was only during hospitalization we gave, but we did not give her during the thing. Okay. So she responded very well now. So we continued on steroids and once we reached 10 milligrams, we are continuing 10 milligrams of steroids as well as azathioprine and UDCA. Okay.
Yes.
So what are the points you would want to look for? When will you like to consider colectomy in this patient?
Sir, because of the PSC, the ulcerative colitis is at a very high risk of going into a colorectal cancer. So she would require an accelerated surveillance protocol. That is, as soon as after the diagnosis of PSC, she needs to undergo a surveillance colonoscopy annually. If there is
annual colonoscopy to look for
any dysplasia
and look for dysplasia or derm lesions. Okay.
Yes, sir.
That is one thing. And second thing is you also need to look for surveillance of in the liver. What do you want to do a surveillance for?
In the liver, what will you look for?
Look for
Part of surveillance.
The
suddenly an
development of
alkaline
hepatocellular
phosphatase, not HCC. We need to look for cholangiocarcinoma.
cholangiocarcinoma. Sorry.
So when you look for any new or suddenly the CA99 goes up, or if she worsens, 2 things can happen. Either the strictures have become dominant, or she could have developed a
Cholangiocarcinoma.
CCA, intrahepatic cholangioCA. Okay, intrahepatic cholangio can come as a mass lesion, or there can be a new stricture in the intrahepatic bilirubin which will enhance during CT. Okay, so there is sudden enhancement of any stricture or something. But CCA does not enhance like HCC. So she has to be put on a surveillance victim. So if she has it, you undergo colectomy. Does she require always colectomy before liver transplant? Supposing she worsens further and she requires a liver transplant.
Yes, sir. Sir, studies have shown that after a liver transplant, the ulcerative colitis activity can get enhanced. In fact, there's a further risk of developing colorectal cancer. So colectomy is generally suggested at the time of liver transplant or just prior to the liver transplant.
Not necessarily we did not list her for liver transplant because I think her dominant picture was more of autoimmune hepatitis than PSC, and she responded very well. Now she has an albumin of 4, PTINR of 1.2, bilirubin of 1, and everything we continued. So suspect autoimmune liver disease in IBD, the elevated globulins, raised alkaline phosphatase. It's important that you look for SCCA, okay, and look for a colonic cancer. So here we did not really, because I don't think she never is jaundiced, bilirubin. So I don't like to send somebody, even a PS, if you don't have jaundice and ascites has completely responded. The second point is an autoimmune cirrhosis also can respond very well to steroids. So just because they are decomposite in autoimmune hepatitis, you don't need to rush for a transplant. Some of them will very well respond to respond to your 92% of these patients will respond to steroids and azathioprine. That's what the famous paper from Chaya's group has come. But at the same time, about 18% of patients with autoimmune hepatitis can come with an acute liver failure. They may require a transplant. So in this case, we thought autoimmune was more dominant than this thing. The third thing you should know is how do you diagnose overlap? So please read up the complete Paris criteria. How do you diagnose autoimmune hepatitis and overlap? So it is necessary that 2 out of 3 points have to be given. And please, all the candidates, please look through Paris criteria for overlap. Okay.
So thank you, Dr. Rohan. You have discussed it very nicely, and
Thank you,
congratulations, and wish you all the best for your examination. Okay,
Thank you.
just brush up things. That's all. Okay, Professor Venkat, we have one more case which we won't discuss, but we will show the slides, and perhaps you can tell the impression at the end. We'll run it fast.
Yeah, she's a 60-year-old female presented with progressive jaundice for 1 month, and she came to us with abdominal distension for 10 days and pedal edema intermittently for 3 months. No prodromal onset. There was no fever, no arthralgia. Had melena of 1 episode. She was sent to us mainly because she had 1 episode of melena. She also had pruritus for 6 months, more in the nights. She is a diabetic for 22 years, underwent CABG 12 years back, had diabetic nephropathy with a CKD of stage 5 for the last 2 years with a creat of 5.1. She was denied they did not recommend a transplant because she had a very, very poor vascularity because of diabetes, and her heart was not good because of her CABG. Was admitted and transferred to us due to altered sensorium and melena. When she came to us, the pruritus worsened, but she has been on CAM 3 months before the onset of jaundice. Also took another set of CAM 21 days after the onset of jaundice. Nutrition history was a poor intake for 1 month due to abdominal distension and low salt. Can we have the next slide, sir? So issues were that she had diabetes, post-CABG, chronic kidney disease. She had a pruritus for 6 months and progressive jaundice for 1 month. Prior to that, she took complement and alternative medicine for nearly 3 months for the pruritus and progressive pedal edema and abdominal distension for 10 days. The pruritus, we thought it could have been due to chronic kidney disease. And she came here because she had a GI bleed, and after GI bleed, she had altered sensorium for 2 days. So basically, I think what she now has is probably she has got into some sort of a chronic liver disease, which could be viral, it could be drug-induced, it could be any autoimmune or any of these things, or it could also be due to vascular, some obliteration of the small vessels in the thing because of the CAM. The investigation done outside showed a bilirubin of 82.1. She had elevated alkaline phosphatase and gamma GT. And they did ultrasound abdomen, and because of renal failure, they did a CT plane with a mild surface nodule of the liver and portal vein ascites. Other gastroenterologists went to them and saw, and he advised MRCP to rule out because she had intense pruritus and elevated alkaline phosphatase, and MRCP was normal. She had a normal platelets. Here at PSG in our place, she had a hemoglobin of 6.3, PCV of 18.6. INR was okay. I think creatinine was 5.9 and sodium was 133. And potassium and bicarb was 13.2. Okay. Bilirubin was 16. She had a elevated alkaline phosphatase. The serum ferritin was grossly elevated, and her transient saturation, however, was only 46. Ascitic fluid showed a low protein, high SAG ascites. Can we have the next slide, sir? All her serology was negative. Her anti-HBC total was positive. However, HBV DNA viral load was negative. She had a mild 1+ SLA positive. Remember, some of these drugs can induce some autoantibodies. Can we have the next slide, sir? Ultrasound did not show any edematous gallbladder. Liver was mildly coarse. There was a moderate ascites, and portal vein was about 13 millimeters. She had a slight drop in hemoglobin. Bilirubin increased to 22. She had enterococcus faecium. She had treated linosin. Counts regressed to 18,000, but bilirubin is persistent at 22.8. Can we have the next slide, sir? So what we did here was she had a CAM. She had a chronic kidney disease, diabetes mellitus, post CABG. The pruritus we thought was because of her intense uremia, what she had. But she took CAM and she came with progressive jaundice and ascites. In fact, ascites was very disproportionate for the albumin or the prothrombin-time, everything. So, and all her serology was negative. And after sending the CAM to our pharmacy, pharmacovigilance department in College of Pharmacy, we went ahead and did a transjugular liver biopsy. In the transjugular liver biopsy, the hepatic vein wedge pressure was nearly 18. That means she has developed a portal hypertension. Upper GI scopy did not show any varices. There were only some small erosions. So when we looked at the biopsy, predominantly it was initially macrovascular steatosis, mainly because I think drug induced. And there was also a lot of miliary hyaline and neutrophilic infiltration. Can we have the next slide, sir? And most importantly, she developed a lot of this pericellular fibrosis, and majority of the fibrosis were seen around the sinusoids. Actually, the first side, the more intense fibrosis and the blue lines, what you saw was a severe fibrosis due to, there was severe fibrosis around the sinusoids rather than the portal tract. So this is basically a drug-induced sinusoidal fibrosis. There were intracanalicular and canalicular cholestasis. There was widening in the portal tract thing, but most of the portal and portal fibrosis and portocentral fibrosis ductal operation. But majority of the fibrosis were around the around the sinusoids, and the hepatocytes were arranged in nodules. So there was something like sinusoidal fibrosis with nodular regeneration, and they called it as an incomplete cirrhosis. So ultimately, this biopsy showed drug-induced sinusoidal fibrosis, later moving on to develop incomplete nodule formation and incomplete cirrhosis. There was also cholestasis in this patient because of drug-induced. There was also steatosis in this patient because of drug-induced. And there was also, because the inflammation was being going on, there was also portoportal and portocentral fibrosis. So this is just to show a patient where a drug can cause, how it can cause both cholestasis, it can cause portal fibrosis, and most important. But when you look at the fibrosis, it is predominantly look more towards the sinusoids. So this is akin to some sort of, it's not a classical sinusoidal occlusive syndrome, but this is a drug-induced sinusoidal. First, it has affected the sinusoids, and later went on to cause nodular regeneration, incomplete septal cirrhosis, and portocentral fibrosis. Classically drug-induced. And when we send this material to the thing, it came out that most of these had plant alkaloids, and this one of the alkaloids was called as I don't have the report, and it also contained a lot of plant sterols. So the sterols would have caused fatty liver, and these alkaloids would have caused sinusoidal fibrosis. There is a new entity called portosinusoidal vascular diseases, which causes predominantly sinusoidal occlusion and portal hypertension. Please look through that because there are many causes of it. NCPH comes into that, and IBD can also be a cause for this portosinusoidal vascular disease. This is something which you should know. This is not a classical sinovascular disease, but this is a drug-induced which caused predominantly sinusoidal obstruction and fibrosis, leading to portal hypertension, and then incomplete cirrhosis.
What is talking? Dr. Saji Sebastian. Okay. Professor Venkat,
Yes.
what are the other drugs used in our modern medicine which can actually produce sinusoidal obstruction syndrome?
Majority more than plant alkaloids. Some of these chemotherapeutic agents can produce. Now we are also looking at some of these immune checkpoint inhibitors, which can cause sinusoidal plus autoimmune liver diseases. So all these things there are a lot of other drugs like cyclophosphamide, chlorambucil, all these things can produce sinusoidal. Interestingly, IBD can also produce. And recently we have a patient who has got IBD and just IBD and looking at the IBD for nearly 22 years. 2000 it was diagnosed. Suddenly we found that he's got a surface irregularity and biopsy was predominantly of sinusoidal, but in most disaster was he's also got a HCC. Since it's well compensated, on 4th September, we are planning a laparoscopic resection of the segment 4. So it can happen, Crohn's disease, and there is an article of portosinusoidal vascular disease where a lot of things can go. NCPH, small thrombophilic conditions which can cause obliterative venopathies, IBD, drugs, all this can cause NCPH-like syndromes.
Thank you very much for that great clinics. And Jayanti ma'am, anything to say?
I was just interested in the second case, no, where the patient had very high transaminitis. So just wondering, 660, I think, was AST/ALT. So just wondering.
The transferrin saturation was 46%. It's not above 50%. We take 50% as a higher.
Not that, AST/ALT. The AST and ALT was quite high, apart from gamma.
Yeah, she also had a lot of steatosis, steatohepatitis. She's also got cholestasis. I think these are all drug-induced what has caused this problem.
Yeah, that's what must be.
I think brush up. I think for the residents, brush up drug-induced liver disease. At least a couple of names for each of the entities, different entities like SOS, all those things. No, and chemotherapy-induced liver disease is a new group of disease. So just brush up all those things.
Radiation-induced, plant alkaloid-induced, yeah.
Ma'am, can you mention say something about the coming class on nutrition? It's on a Friday. It's Friday, 8 p.m. No?
On Friday, 8 p.m., we have requested Dr. Ritu from PGI Chandigarh to speak to us on how to provide nutrition to a patient who's got malabsorption, and is totally cachectic and marasmic with a BMI of say 14 and with or without small bowel obstruction. So we're just requesting her to speak to us only on the diet management, how to supplement in this particular scenario. That will be at 8 p.m. on Friday. And this is mainly for the DNB postgraduates appearing in the first week of September. So,
okay, so the Friday 8 p.m. we have a nutrition support, and the 31st we'll have a GA radiology also. And with that we finish this season's class, and from September we'll be starting next season class. Okay, so I thank all the faculty members who have contributed, especially Professor Venkat, Jayanti ma'am, for their immense support for these classes, and also thank all the residents who have been active in the discussion. And I hope they all have learned a lot, and I wish the very best for all the residents. We have 2 more classes, but not interactive. The next 2 classes will be mainly sort of a direct lecture. So thank you, Professor Venkat, once again for that fantastic class, and good night to all of you. Jayanti ma'am, you want to add anything?
On behalf of all of us, the entire faculty of Kerala chapter and Tamil Nadu chapter, we wish all the PGs blast off, okay? Take off like a rocket and you'll all get through. 100% results, okay? All the best from LBK, all of us here.
We all want all of you to pass.
100%, yeah. Thank you.
Good night all of you. Good night.
Thank you.